I'm going to talk about acute perforated diverticulitis. You're in the OR now, so we're not going to talk about how you got to the OR. So you're already there. We're going to talk about the surgical options. I don't have any disclosures. I could have titled this talk just bomb, because that's about what it looks like when you get in the abdomen in some of these cases of perforated diverticulitis, like a bomb went off. So that could have been just the title, but no talk on diverticulitis is complete without a picture of this surgeon mentioning him. Does anybody know who this is?
Of course.
Dr. Trudell?
John Hinchey.
That's right. This is John Hinchey. 1978, came out with the Hinchey classification. He's from Montreal, McGill University. He's still living. And when this talk's mainly going to pertain to Hinchey 3 and Hinchey 4, fecal peritonitis and purulent peritonitis. Well, the surgical options are the newcomer to the block, laparoscopic lavage and drain, resection with anastomosis, plus or minus an ileostomy, and then the Hartmans, which we all know and love. And then possibly diverting colostomy, but there's a caution to that, and we'll go over that. Well, the Hartmann procedure, first described by Henry Hartmann, a French surgeon in 1921, for two patients with an obstructing sigmoid cancer. It was actually not diverticulitis, but cancer that this operation was first described for. It replaced a three-stage procedure described by Mayo, where patients would be diverted with a colostomy, then have a resection, then have a colostomy reversed. But that procedure had a high infection rate and a high mortality rate. The mortality rate of the Hartmans was only 14% compared to 44% for the three-stage procedure. Now, this was back in the era before we had big gun antibiotics or any major antibiotics. So the inflammation mattered. The proximal colostomy does not control the inflammatory process. So the Hartmann procedure was this new magic bullet that they came up with. It's been considered the gold standard for perforated diverticulitis for decades. However, while safe, it has a high morbidity and a lower rate of stoma reversal compared to other operations, as you'll soon find out. And a Hartmann's takedown is associated with significant morbidity and can be technically challenging. They're some of the hardest operations we do, a Hartmann's takedown after a bad case of perforated diverticulitis. So if we can avoid the Hartmann's, that would be great. Well, what about this minimally invasive laparoscopic lavage? Back in the early 2000s, mid-2000s, it was the newcomer. It was minimally invasive, seemed like it was the emperor's new clothes, first described by O'Sullivan from Dublin in 1996, mainly for Hinchey 3 non-feculent purulent diverticulitis. His colleague Myers, also from Dublin, published a series of 100 cases in 2008. It looked great. 8% conversion to Hartmann's for Hinchey 4, which is appropriate. 4% morbidity, 3% mortality. Only 2 patients had a recurrence at 3 years, and only 2 patients required intervention for pelvic abscess. But the story is never that good, just like in fistulas. It's never that good, so it seems. Well, there's a lot of data on this topic, and we're going to dive into it a little bit. I don't want to get lost in the weeds of the data, but there have been 3 prospective randomized controlled trials looking at laparoscopic lavage versus resection, meaning either a Hartmann's or an anastomosis with or without an ileostomy. The Ladies trial from the Netherlands, the Scandinavian trial from Norway and Sweden, and the Dalala trial from Sweden and Denmark. The Ladies trial had to be discontinued early because it was high morbidity in the laparoscopic lavage arm, 39% versus 19%. In the Scandinavian trial, they had a high deep organ space infection rate, sepsis of 32% in the lavage arm versus only 13% in the resection arm, and the unplanned reoperation rate is significantly higher, 27% versus 10%. The Dalala trial was the only trial that showed laparoscopic lavage in a favorable light, but the endpoint of the study was operations within 1 year. So the 1 year reoperation rate was higher in the resection arm because a lot of these patients had a Hartmann's and needed a Hartmann's takedown. So it's a little bit spun, the way they spun the result of that trial, because 63% had a reoperation rate in the resection arm because they had their Hartmann's taken down. The Sheikh et al. Did a meta-analysis and a review of all these trials together with an N of 372, and not surprisingly showed that laparoscopic lavage showed increased deep sepsis and increased percutaneous drainage as a result. That was significant. Well, Nancy Baxter actually looked at all this in a very elegant study she published in Diseases of Colon and Rectum in 2018, looking at these trials. And if you look at the graph, as far as postoperative complications, clearly favors resection, meaning less complications in the resection arm. All the bars are on this side. So that doesn't bode well for laparoscopic lavage. As far as early reoperation, again, more reoperations in the laparoscopic lavage group. That, again, favors resection. Mortality was about the same in both arms. So it concluded that laparoscopic lavage is associated with increased risk of recurrent abscess, peritonitis, and reinterventions, whether reoperation or percutaneous procedures. It's associated with decreased length of stay and operative time, which is not surprising because it's minimally invasive. But it cannot be recommended as a standard of care or as an alternative to colon resection for Hinchey 3 diverticulitis. Well, what about a Hartmans versus an anastomosis? Mainly done, as I mentioned earlier, for Hinchey 3 or Hinchey 4 diverticulitis. There have been 4 prospective randomized controlled trials looking at this, all from Europe. First one was the Diverticulitis trial from France. The second one was a multi-center trial out of Europe. The third one was from Switzerland, and the last one was from Italy, Belgium, and the Netherlands, the LOLA trial. Also, 2 meta-analyses that combines all these trials and some other data from almost 1,000 patients each. So there's a ton of data on this topic. And if you look at a summary of these trials, the BINDA trial, there was no significant difference in morbidity or mortality if you did a Hartmans or an anastomosis, and that's with or without an ileostomy. The Switzerland trial, again, no difference in morbidity and mortality. The stoma takedown rate was much higher if you did a resection with an anastomosis versus a Hartmans, 90% versus 57%. So if you hook somebody up at the beginning and gave them a diverting loop, you had a much higher rate of a takedown as opposed to a Hartmans. And then the meta-analysis kind of mirrored those results. No difference in mortality between the 2 arms. There was a decreased rate of deep sepsis and wound abscesses in the patients that got hooked up. And the other meta-analysis showed decreased, actually, mortality in the patients who got hooked up. Now, that could be because patients that had a Hartmans were sicker to begin with and had a higher mortality rate, and that's why they got a Hartmans. And then a decreased length of stay in the patients who had an anastomosis with or without an ileostomy. Well, Nancy Baxter, again, looked at these trials in her study as well. If you take the Hartmans versus anastomosis, again, neither one of them, as far as complications, it's about the same, no difference. Mortality, no difference. The line is in the middle. But this is the fascinating part. Stoma-free at 12 months clearly favors primary resection with anastomosis. And if you look at complications of stoma reversal, so Hartman's takedown versus ileostomy takedown, all favors primary resection with anastomosis and diverting ileostomy. As I mentioned, the Hartman's takedown is a morbid procedure. So Nancy Baxter in her article concluded you have a lower rate of stoma reversal and a higher rate of complications after Hartman's, suggesting that primary resection and anastomosis is the optimal management of perforated diverticulitis. But as I'm soon going to show you, that's actually not the case nationwide. Well, when do you do a Hartman's? Well, certainly if there's risk factors for mortality and it's been shown that steroid use, ASA greater than 3, age greater than 80, Hinchey 4, feculent peritonitis, chronic renal disease, malnutrition, and recent radiation are all factors that probably warrants a Hartman's as opposed to an anastomosis. Well, what about the 3-stage procedure that Mayo described way back when? Now that we have better critical care and big gun antibiotics like Zosyn, can you do this with minimal morbidity? Because there was high mortality in this way back when. Well, there's actually a study on this published out of France in 2000 at British Journal of Surgery. It was a multi-center randomized trial where they did a primary resection with a Hartman's or an anastomosis. Turns out most patients got a Hartman's. Versus a secondary resection, which means diverting colostomy, resection, and then a takedown, the so-called 3-stage procedure. 52 out of 55 patients in the primary group got a Hartman's procedure. Well, if you look at this, early operation rate was much greater if you just diverted them, 9 versus 2, and the postoperative peritonitis rate, again, much higher, 10 patients in the colostomy group versus the Hartman's group, meaning diverting colostomy. And then length of stay, also much higher, 24 days versus 15 days. So if you gave them a colostomy, they actually stayed longer because of infectious complications and more reoperations. So primary resection has a lower rate of postoperative peritonitis, fewer reoperations, shorter hospital stay. Mortality was the same, possibly because we have better critical care. But is there a role for diverting colostomy in this scenario? Maybe. If the resection is not safe or too difficult, it could be your bailout if you don't want to cause any harm. And I've done this a couple times in patients who were on chemotherapy that had to get back to finishing their chemotherapy as quick as possible, and you didn't want to wait for a long recovery where they had chronic smoldering diverticulitis. You could give them a diverting stoma to get them through the rest of the chemo. But that's not really Hinchey 3 or Hinchey 4. Well, what about surgical training? Does it matter who does the operation? New York State Department of Health database was using this study out of Mass General with Liliana and her group. They looked at 10,780 patients who had underwent urgent or emergent surgery for diverticulitis. Most were done by general surgeons, 94%. Only 6% were done by colorectal surgeons. This tends to be a disease that's seen by acute care surgery services. 98% got a Hartmann's procedure. Only 1.7% got primary anastomosis with diversion. And even those patients that got the anastomosis, 1.5% of general surgeons hooked them up, and only 4% of colorectal surgeons hooked them up. Now, it also could be the nature of the disease. You don't know in this big databases. But the interesting thing they found as far as mortality goes, when a general surgeon did the operation, the mortality was much higher if patients got an anastomosis versus a Hartmann's. With a colorectal surgeon doing the operation, the mortality was the same. Now, again, this is selection bias. The colorectal surgeon might have got patients that were less sick. Morbidity mirrored the same results. Higher if the general surgeon did the operation versus the colorectal surgeon showed no difference in morbidity if there was an anastomosis versus a Hartmann. So this study is fraught with selection bias. However, they did conclude the safety of an anastomosis in the emergent setting remains questionable, although that has been debunked by the prospective randomized trials that I showed you. A vast majority of emergent operations are not performed by colorectal surgeons, which is not surprising. Colorectal surgeons did have decreased mortality regardless of the operation, which may be selection bias, but even if performed by a colorectal surgeon, 96% of the time the patient got a Hartmann's, despite with the data I showed you. So what about the treatment algorithm? This is a nice flow chart just recently published in last month's Diseases in Colon Rectal Surgery by the Residents Corner. And if you have freely perforated diverticulitis, Hinchey 3 or Hinchey 4, and they're hemodynamically unstable, the answer is easy. You should give them a Hartmann's. If they're stable but immunosuppressed, malnourished, they have Hinchey 4. If there is concern for anastomotic integrity or you can't safely perform an anastomosis, then you should do a Hartmann's. Otherwise, primary anastomosis and ileostomy is probably the procedure of choice based on the data that I showed you. So to conclude, laparoscopic lavage is not recommended for Hinchey 3 diverticulitis based on the randomized controlled trials. Primary resection with anastomosis with or without ileostomy, diversion, is the procedure of choice for perforated diverticulitis. It has similar morbidity to Hartmann's. It has increased rate of stoma reversal 1 year. Hartmann's is still the gold standard in unstable patients and patients with risk factors for mortality. And despite data showing primary resection with anastomosis may be superior, Hartmann's is still the most prevalent operation performed for perforated diverticulitis. Thank you.